The hidden cost of skipping frailty assessment. A brief summary of our latest GlobalRPh article. Why it matters. Frailty, marked by reduced strength, endurance, and physiologic reserve, is common, approximately 15% of non-institutionalized U.S. adults, up to 27% globally, and more prevalent in women than men. Yet it remains underassessed in routine care, and only a tiny fraction of studies use frailty measures to actively guide management. That gap has real consequences: worse outcomes, higher readmissions, and avoidable costs. Frailty beats age as a prognostic tool. Chronological age is a blunt instrument. Frailty more accurately reflects biologic age, predicting adverse outcomes across settings. Mobility and activities of daily living, ADL, decline. Frail adults have a 1.3 to 2.6-fold higher risk compared to non-frail adults. Mortality, approximately 3.5 times higher overall, around 8 times higher in hospital mortality. Hospital utilization, frail patients have a longer average length of stay, approximately 13.5 days compared with 8.3 days for non-frail patients. Even pre-frailty carries risk, approximately 1.5 times higher functional decline, underscoring the value of early detection. Crucially, frailty is dynamic and modifiable, allowing targeted intervention. What's lost when we don't assess? Readmissions and missed diagnoses. Frail patients experience a 24% rate of 30-day readmission or death, compared with 14% among non-frail peers. The risk rises sharply after the first week following discharge and remains elevated over 90 days, with nearly 40% requiring emergency department revisits. In the absence of systematic screening, geriatric syndromes, including cognitive impairment, malnutrition, depression, and fall risk, are frequently missed or recognized late. Moreover, frail patients are less likely to receive timely assessments or specialist consultations during acute hospital care. Missed prevention windows. Skipping assessment forfeits prehabilitation, early rehab, medication optimization, and safer care transitions. These are the very levers that reduce hospitalization, institutionalization, and functional decline. The economic drag. Unrecognized frailty inflates costs via prolonged admissions, ICU days, complications, and post-acute needs. Length of stay. Median hospitalization is approximately 20 days for frail patients, compared with 12 days for non-frail patients. ICU stay. Median duration is approximately 8 days for frail patients, compared with 6 days for non-frail patients, with higher 6-month mortality observed among long-stay patients. System costs. Annual per-person spend climbs steeply with frailty severity. Hospitalizations drive approximately 2/3 of spend. In surgery, adjusted costs for frail patients can be nearly double, especially after complex operations. Team-based staffing models, which include nurse practitioners, NPs, and physician assistants, PAs, can enhance the consistency and scope of patient assessments and may help reduce labor costs. But these benefits are realized only when frailty is systematically identified and addressed. Surgical decision-making. Risk without a compass. Frailty transforms even minor procedures into high-risk operations. 30-day mortality. Approximately 1.5% following low-stress procedures, and over 5% after moderate stress procedures, exceeding the 1% threshold that defines high surgical risk. In the very frail, rates exceed 10% for minor and approach 20% for moderate procedures. 180-day mortality can exceed 40. Without a frailty score, such as Risk Analysis Index, Clinical Frailty Scale, teams miss chances to align goals, optimize pre-op status, or pivot to non-surgical palliative strategies. Prehabilitation can reduce complications by approximately 16%, but requires early identification. Proof that assessment changes outcomes. Health systems that implement routine frailty screening, such as Preoperative Risk Analysis Index, RAI, or Clinical Frailty Scale, CFS, assessments at admission have reported lower postoperative mortality, particularly among frail patients. Recognizing frailty early also helps predict discharge destination, functional recovery, and quality of life, allowing for timelier rehabilitation and support planning. Clinical trials indicate that frailty status can improve within 1 year for a significant proportion of patients when it is identified and managed proactively. Why tools aren't used and how to fix it. Key barriers include inter-rater variability with tools such as the Clinical Frailty Scale, CFS, time constraints in emergency and intensive care settings, the absence of a single gold standard assessment, insufficient training, and fragmented data within electronic health records, EHRs. Practical fixes. Rapid screening tools in primary care include the Frail Scale, completed in 15 to 30 seconds, the Vulnerable Elders Survey 13, VES 13, and the Rapid Geriatric Assessment, which takes under 5 minutes to administer. Integrate frailty screening into routine encounters such as Medicare annual wellness visits, and use triage prompts to flag concerning signs, immobility, recurrent falls, cognitive decline, and polypharmacy. Automate follow-up actions. Configure electronic health record (EHR) triggers to initiate comprehensive geriatric assessment (CGA), physical and occupational therapy (PT/OT), nutrition and pharmacy reviews, and social support referrals when frailty score thresholds are met. Team-based care. Empower nurses, nurse practitioners, NPs, physician assistants, PAs, and pharmacists to conduct frailty screening and initiate appropriate care pathways. Bottom line, frailty assessment is a high-value, low-effort addition to routine care that more accurately predicts decline, readmission, and mortality than age alone, while also identifying modifiable risk factors. Health systems that implement frailty screening report fewer complications, shorter hospital stays, improved quality of life, and reduced costs. Make it standard practice, screen efficiently, refer positive cases for comprehensive geriatric assessment, CGA, and act promptly on identified risks. Key points. Frailty predicts outcomes better than age. Skipping assessment drives readmissions and costs. Surgical risk stratification requires a frailty score. Rapid tools enable easy adoption. Early identification opens a path to reversal. If you found the content valuable, please consider subscribing and giving this video a thumbs up. Your support helps us continue delivering high-quality, evidence-based medical content tailored to healthcare professionals like you. We have more in-depth topics and clinical insights coming soon, so stay tuned and we'll see you in the next video.